Welcome, everyone, to the Transformation Nurse Academy podcast. This is our weekly episode, Talk with Kevin, where we cover topics for all nursing fields with extra emphasis on emergency and critical nursing. Get ready for candid discussions that explore the vast landscape of nursing and beyond.
Hope you fucking guys have been doing all right, and gals. When I say guys, I mean everybody and shit, so don't fucking get all offended and shit. So I hope you had a great week. I took the last week off because I'm fucking tired and shit. Miss Pat got me working too goddamn much and shit. So anyway, I appreciate you guys. I hope that you enjoy this episode. This is a episode that I'm going to talk about a case study. It's a nurse, and I'll put the link in so that way you guys have the link, and Jane will have the notes and stuff. Sorry, Jane. All right, so this is a nurse case study where a nurse floats, and it says, float nurses' failure to follow sepsis protocol guidelines and institute chain of command contributes to extensive patient injury. So I'm going to read this. This is from NSO. If you don't have medical malpractice, I encourage you to get it. There's medical malpractice through NSO, and then there's also cmfgroup.com. So it says the insured was a registered nurse who was recently hired as a per diem float at a local community hospital. Sounds familiar, doesn't it? On the date of the incident, the insured RN was working in the emergency department. Pay attention, you sons of bitches, floating from med-surg to ER or from ICU to ER. So it says the RN insured was working in the emergency department and was assigned to a female patient in her 40s who presented with complaints of abdominal pain, fever of 104, chills, and vomiting. The patient had past surgical history of a splenectomy, which was not included in the initial ED nursing assessment. The initial assessment performed at 7 o'clock revealed that the patient was hypotensive, tachycardic, prompting the insured RN to initiate the sepsis protocol. Place an order for the recommended laboratory test and notify the ED physician about the patient's condition. The ED physician acknowledged the nurse's concerns but did not share her sense of urgency. So the reason why I'm sharing this, because I've had the personal experience here, now that I'm going back to the hospital 4 days a month. Twice, if not 3 times now, I've had this same issue where I come on, I get report, vital signs similar to this, and I get the same sense from these nurses that I took report. They don't have an urgency, or they don't make the doctor have the urgency that I feel they should need. So if you got a patient that has crazy vital signs and you go to the physician and the physician's not doing anything, fucking walk up to them and say, listen, bitch, you need to come see this patient. Because if you don't, look, right here, you're going to get in trouble. So at approximately 8 o'clock, the ED physician conducted an initial evaluation. So that's an hour later that this patient's been just sitting. Finally, the doctor an hour later ordered fluids, documented that the patient was tachycardic and did not appear to be septic. How can you look at a fucking patient and say, oh, that patient doesn't appear to be septic? That's why we do laboratory studies, bitch. So over the course of the next 1 to 2 hours, the RN remained concerned about the patient's hypotension and tachycardia and the fact that the laboratory results were not yet reported. So here you are, you've drawn a lactic acid, I hope, because I don't see anywhere in here that it talks about that yet. White count, anion gap, things like that. Why aren't you looking? And if they haven't been resulted within, 15, 20, 30 minutes, call the fucking lab. Beat their door down and say, where's my fucking shit? All right, so anyway, over the course of the next 1 to 2 hours, the RN remained concerned about the patient's hypotension, tachycardia, and the fact that the laboratory results were not yet reported. Upon contacting the laboratory to investigate the status of the lactic acid, among others, the nurse was informed that the test was not being processed because the proper ordering protocol was not followed. What the fuck does that mean? So this is where you as a nurse have to follow up because you can't trust fucking nobody. In an attempt to advocate for the patient, RN became hostile. Okay, well, even though I am assertive, I don't become hostile. So I don't know if that was something that somebody in the article wrote or what does hostile mean. So don't fucking become hostile. Become assertive. Anyway, the RN became hostile with the laboratory staff for their refusal to assist, and a verbal altercation ensued. It must have been something that Kevin would have done. Listen, bitches, where's my fucking test and shit? You better run this. I'm gonna come down and I'm gonna burn the motherfucking hospital down. All right, so anyway, notably, the hospital was on a planned downtime procedure for Epic computer-based orders. I love computers and shit, don't you? But I don't fucking love Epic, not yet. So fuck all you bitches who love it, including you, Nikki. All right, so anyway, requiring the use of alternative paper methods for ordering diagnostic studies. Although the insured RN completed the hospital online training for downtime procedures, the procedure for manually labeling specimen was not followed. So this is the big issue at a hospital I work at. If you don't do it correctly, the lab is going to reject it. And if the lab rejects it, now your patient's delaying treatment. So this is why it's important to read policies, understand, ask questions, get your charge nurse involved or something. You can't just wait till the fucking patient an hour or two until you get the damn results back and shit. Anyway, the RN repeatedly reported the patient's deteriorating condition to the charge nurse and ED physician. So if it was reported, was it documented? Because if you say you reported, but you didn't document that shit, it ain't done. Don't trust motherfucking bitches except yourself. All right. The RN repeatedly reported the patient's deteriorating condition to the charge nurse and ED physician and was instructed to give more fluids. Now, I don't know if anybody knows about Kevin, but I'm not a fucking fluid person. You're only patching the problem, but you're not fixing the underlying problem. If a patient is in sepsis, look at the new sepsis protocol. You should start antibiotics within 60 minutes. You should give 30 milliliters per kilogram per hour of isotonic crystalloid solutions. And if you need to provide pressors. If you don't understand the sepsis process, that is your job as a professional to go read the new guidelines. And there's a thing called saving. Let's see, was it saving sepsis campaign or something like that? I'll get the website and I'll give it to Jane as well because that's something that you should be paying attention to. So they ordered the patient. I'm sorry, they ordered the RN to give another 1,500 cc's of fluid, which had already been infused over a 2-hour period with no improvements in vital signs. That's because you haven't given the motherfucking antibiotics. So my question to you as RNs, and I ask every RN who comes to my class, how long does it take IV antibiotics to start working? Put that in the comments when you see this video. How long does it take IV antibiotics to start working? And why do you need to give that shit in the first 60 minutes? All right, so the ED was extremely busy. I can't imagine that shit. EDs are never busy. The ED was extremely busy, and the recently hired RN was not familiar with support available through the hospital chain of command. Listen, bitches, the hospital chain of command and support is the same no matter where you go. You start with your charge nurse, then you go to the fucking manager, then you can go to the house supervisor if the manager's not there. You can go to the doctor, to the medical doctor, tell somebody that you're going to write an incident report with their motherfucking name on it if they don't see the patient. All right, so anyway, the ED was extremely busy, and the recently hired RN was not familiar with support available through the chain of command. Due to an escalating concern for the patient and overwhelmingly sense of frustration, the RN verbally attacked the ED physician. Verbally attacked. How many times do nurses get verbally attacked by the physicians? Man, fuck you bitches. Grow some fucking balls and some hoo-haws and quit crying and shit if you get verbally attacked. Do your fucking job and we won't verbally attack your dumb asses. All right, so the RN verbally attacked the ED and the charge nurse regarding their apparent lack of concern and urgency about the patient. The following day, the RM was reprimanded for this conduct. Well, how come fucking doctors don't get reprimanded when they verbally attack us? How come charge nurses and managers and directors don't get reprimanded for verbally attacking us? Fuck you, bitches. At approximately 12 o'clock, the laboratory called the report. Imagine this, report a critical result. A white blood count of 26. At the same time, the chest X-ray report confirmed the presence of pneumonia. So when you get somebody with suspected pneumonia, you only have 30 minutes to get the damn chest X-ray upon arrival, 45 total minutes to read it, and an hour to give it the antibiotics. You don't have time to fuck around. So if you don't know what core measures are, learn your core measures. All tied to money. Tell them they ain't gonna get fucking paid. Based upon the results as well as the patient's critically low systolic blood pressure in the 70s, antibiotics were finally ordered. Holy shit. So from 7 o'clock to 12 o'clock, that's 5 fucking hours that they did not get the antibiotics. So again, you have to give antibiotics with suspected sepsis or infection within the first hour. And my question again is, how long does IV antibiotics take to work? So the blood pressure was in the 70s, antibiotics were ordered, and the patient, oh, it says it was ordered, but it doesn't say given. And the patient was transferred to the ICU. Imagine that shit. The physician transfer note listed the patient's diagnosis as sepsis and pneumonia. 7 hours after the patient's presentation to the hospital. 7 hours after the patient presented to the hospital. That's when the antibiotics were finally given. So that's fucking crazy as shit. And they were administered not in the ED, but in the fucking ICU. So that, no matter what excuse, that's on you as a nurse. Even if you're busy in the ED, you got to make sure that this gets done. Because look, the doctor's going to chart that they ordered whatever and you didn't fucking do it. So you got to speak up, even if you get reprimanded and shit. Your job is patient safety, not to make fucking people happy. The patient's condition continued to deteriorate and is evidenced by ongoing tachypnea and tachycardia. There was a critical serum lactic acid level and a mean arterial pressure below 65. So if you have a MAP below 65, that means you're not getting enough cerebral peripheral perfusion. If you've never heard of it, it's called the Monroe-Kelly doctrine. The normal CPP is 60 to 100. The normal MAP is 50 to 100. And the ICP is like 0 to 15. So MAP minus ICP equals CPP. MAP minus ICP equals CPP. And that's where you want to make sure you have good enough perfusion so you get enough oxygen and nutrients to your patient's brain so they don't become special. The patient required intubation and mechanical ventilation. The ICU physician diagnosed the patient with severe sepsis and shock liver. I never heard of shock liver. In other words, MODS, multi-organ dysfunction syndrome, MODS. That's because down in the ED, this patient was septic. There wasn't a sense of urgency. They weren't getting enough oxygenation to their cells, so they became hypoxic due to the high infection. And so their body was basically shutting down because they only received about 1,500 to 2 liters, and they did not receive the antibiotics within how long? The first hour. Anyway, the ICU patient was diagnosed with severe sepsis and shock liver. The blood culture results were positive for gram-positive bacteremia. Over the next 24 hours, the patient exhibited severe acidosis. Oh, and multi-organ system failure and gangrenous extremities related to the disseminated intravascular coagulation, or DIC. So why does a patient get DIC when they're going into MODS? Because if they don't get to, you remember the triad of death: hypothermia, acidosis, and coagulopathy. Look that up, the triad of death. So high doses of vasopressors were required to maintain an adequate blood pressure. So when you have somebody that's septic, it changes the permeability of your vascular space. And so that's why septic shock is called distributive shock, because your vascular space is so leaky, it's leaking into the extracellular and into the interstitial space. So you can dump a fucking shitload of fluids, but the fluids aren't going to stay in the intravascular space. That's why you need pressors to tighten the fucking blood vessels, butt cheeks up, so the fluids stay where they are. And you need to give the antibiotics so it treats the underlying cause. If you don't do that, you're going to have an increase in cellular hypoxia. And the patient's going to start having coagulopathy issues because you're dumping a shitload of fluids in because you're trying to keep the blood pressure up. And you're diluting the shit out of everything. So your body goes crazy. The family decided to transfer the patient to an academic medical center. where bilateral upper and lower extremity amputations were performed as a life-saving measure. Now, it may be a life-saving measure, but would you really want to be amputating both your upper arms and your lower legs to save your life? Do you want to be a stump for the rest of your life? I don't know if I know the age of this patient. Didn't really say, so I haven't said that, but I have to look at that. Anyway, they transferred the patient. The patient had a bilateral upper and bilateral lower extremity amputation. 2 years later, 2 years after this case was after this nurse had taken care of this patient, that's when they filed a lawsuit against the insured RN, the involved physicians, and the hospital. Who's gonna fucking go underneath the bus? Not the hospital and not the physician. The allegation against the RN was failure to follow the sepsis protocol. So you can't say that it was the doctor's fault when it's your job to make sure that you advocate for your patient. And she did. She tried to advocate, but did she document it? That's where you got to understand. I encourage every nurse to document an incident report, say it out loud. Okay, doc, I'm gonna fucking chart this shit if you don't go fucking take care of this patient. I'm gonna write your name in the incident report. I'm gonna do you, Mrs. Charge Nurse or Mr. Charge Nurse. Your fucking name's going into the incident report. So the expert nursing review for the defense believed that the nurse did not adhere to the standard of care. And my friend Maggie always talks of this. There's your scope of practice, there's hospital policy, but in lawsuits, they call it the standard of care. What is the standard of care for a sepsis patient? To follow the sepsis protocol. So the expert nurse reviewing the defense believed the nurse did not adhere to the standard of care and was unable to offer support during litigation. The following opinions were rendered in the nurse's expert review. So they'll hire somebody like me, who's a certified emergency nurse expert, to review cases like this and give feedback on what the nurse should have done according to the standard of care. So this is what the expert said. This nurse had failure to adhere to hospital policies, procedures, and guidelines regarding the sepsis protocol, which contributed to the delayed diagnosis and treatment of sepsis. So if you don't know your fucking policies and you don't know the standards of care, you're already at a loss and you're going to get screwed in a lawsuit. Lack of knowledge pertaining to the epic downtime procedures for ordering tests. So if you are using computer system charting, which we all do, and you don't know how to fucking manually fill out a fucking fill out a lab report, you should ask and shit. Find somebody to help you, dumbass. Failure to conduct a comprehensive physical assessment and to document the patient's history of the splenectomy, a condition which may predispose a patient to infectious or sepsis. Because what does the fucking spleen do for you? Your spleen is what kind of organ? How are you at higher risk for sepsis and infection without a fucking spleen? That's for you guys to look up. I'm not going to give you all the damn answers. Failure to institute the chain of command whereby an RN may elicit assistance from hospital leadership for unresolved urgent patient matters. You could have went to the damn nursing supervisor of the hospital and say, listen, bitch, I've asked my charge nurse, I've tried to get to the doctor, but they're not listening, and I'm going to document everybody's name in the incident report because nobody is listening to me. So although the insured RN attempted to advocate for this patient, albeit in an unprofessional manner at times, I don't know because I don't know what the bitch said. Critical aspects of the sepsis protocol were not performed in a timely manner. Because remember, you got to give antibiotics within an hour. You got to do a chest x-ray if you suspect pneumonia within 30 minutes to 45 minutes. Critical aspects were not followed. Delays were related to the nurse's lack of knowledge regarding downtime procedure and ineffective communication techniques with clinical team members. So I don't know. It's easy to Monday morning quarterback. I don't know what the fucking nurse said to the doctor or the charge nurse. But look, your policies and the way you communicate and the way you document are going to come back to bite you in your ass. The plaintiff's nursing expert opined, I mean, they fucking read and wrote shit, that the National Sepsis Protocol in place at the time of the incident indicated that the antibiotics should be administered within 3 hours of the patient's presentation. That is no longer the truth now. You have fucking 60 minutes to administer IV in a box. So don't fucking follow this 3 hour shit when sepsis is suspected. In the case, antibiotics were administered 7 hours. So she missed it by 4 hours. And she didn't even do it. The ICU did it. The defense attorney believed that the nurse would make a poor witness at trial due to the harbored anger and resentment about the interactions with the charge nurse and the ED physician, as well as the disciplinary action that ensued regarding her unprofessional communications with the ED physician. That must have been a bitch of an ED physician if they can't take a little fucking directness. During the deposition, and notwithstanding the defense team preparation, the RN displayed a lack of confidence and made contradictory statements regarding the hospital policies. That's because when people get hired, they don't read the motherfucking policies and they don't know it because they're too lazy to look that shit up. So, based upon all of this information, 2 years later, she was sued. She fucking lost $500,000. So, based upon the above defense's challenges and based upon the above noted defense challenges and diminished chance for a successful defense verdict, coupled with the patient's extensive injury and lifelong care requirements, a settlement was negotiated in mediation on the behalf of the insured RN. So she wasn't fucking insured; she'd have to pay out her ass. So the total amount was greater than 500,000. So it says here, figures represent the payments on behalf of the insured nurse and do not include payments that may have been made from co-defendants like the fucking hospital and the doctors and shit. So just know that sepsis is recognized as a global healthcare issue and is defined as a clinical syndrome of life-threatening organ dysfunction caused by a dysregulated response to infection. According to the Joint Commission, sepsis typically affects 1.7 million patients yearly, with about 270,000 of those cases resulting in death. So we kill 270 people. We kill 270,000 people every year. You can't blame the patient. I mean, I know there's comorbidities and things like that, but if we don't follow the sepsis protocol, this number probably could drop. According to the Lippincott Nursing Center, notes that early identification, resuscitation, and the initiation of antibiotics and prompt identification and management of the underlying source. Just what I fucking told you from the beginning. Treat the underlying fucking problem, bitches. And cause of sepsis is imperative in improving patient outcomes. So if you don't recognize sepsis, first of all, and you don't treat the underlying cause and you just throw fucking fluids at it, the patient will not get better and they'll get worse. All right. Patients who suffer sepsis-related disabilities require lifelong medical care, may seek legal recourse with malpractice claims, often asserting delayed or misdiagnosed in treatment. Lapses in the following national guidelines and sepsis bundles to achieve early diagnosis may result in defense challenges in the event that a medical malpractice claim or a lawsuit is filed. So always follow your organizational sepsis protocols. Maintain competencies consistent with current national guidelines. Document all patient-related discussions, consultations, clinical information, and actions taken, including treatment orders that are provided. Document that shit in the patient's chart. Consider utilizing templates for reporting critical clinical information. They have that shit in fucking Epic. It's called provider notification. Become knowledgeable about and invoke the organization's chain of command, which is also probably on your company's website, and then compile a comprehensive patient clinical history as well as relevant information. So this is a lesson for you guys to learn. Surviving sepsis. That's what it's called, Surviving Sepsis Campaign. There's one on the Society of Critical Care Medicine, Surviving Sepsis Campaign. And so if you go on their website and you click on that, just scroll down. It's probably about the second blue box down. It says about the Surviving Sepsis Campaign. And I'm reading. Today is, what the fuck is today? Monday, April the 29th. On their website, it says sepsis and septic shock are leading causes of death worldwide. Implement the Surviving Sepsis Campaign guidelines and the 1 hour bundle and be a part of the international effort to reduce mortality and morbidity. So it's not a 3-hour bundle anymore. It's a 1-hour bundle. And this is where we're getting in trouble because some places are still teaching a 3-hour bundle and a 6-hour bundle. So there's certain things you have to meet in those 3 hours and those 6 hours, but you have to get the patient taken care of in that first hour. So I'll make sure that you guys get this link up here to both the case study as well as the Surviving Sepsis campaign. So that way you can read what's going on. All right, you guys, I hope that you learned a lot. Let's talk about this. I'll post this on our Facebook page and our Instagram and our TikTok. I appreciate you guys listening, and I hope that you take care of your patients a lot better than this person did. And it's not all her fault, but still, you got to speak up because the nurses are always going to be the ones thrown underneath the bus. All right, bitches, I love you. Peace out. Till next time.
Don't miss out. Engage with us weekly. Share your thoughts, and let's transform the nursing landscape together.